Good morning, everybody. Today I am going to present one case, the fever that refused to behave, a diagnostic odyssey. A 19 years old male student admitted with fever for 1 month along with dry cough for same duration. No history of hemoptysis, shortness of breath, chest pain, and there was no history of contact with tuberculosis. But there is history of weight loss, 3 kg last month. Patient is lived in close proximity with farm animals. On examination, only positive findings is pallor and there is multiple cervical lymphadenopathy, supraclavicular, submandibular, submental lymph nodes palpable and tender. The largest one, right supraclavicular lymph node, 1 centimeter into 1.5 centimeter. It was soft, mobile, and tender. The respiratory system examination, upper respiratory tract within normal limit, lower respiratory tract also within normal limit. Other system examination, liver enlarged 2 centimeter below the costal margin, spleen not palpable. So next, the lymphoreticular system examination, pallor, cervical lymphadenopathy, hepatomegaly as present, but there was no splenomegaly, no skin rash or ulceration present, external tenderness also absent. On the day of admission, the blood report reveals anemia having hemoglobin 8.4. Others are within normal limits. That was the chest X-ray showing bilateral consolidation involving the right upper zone, mid zone, as well as left upper and mid zone. The sputum AFP7 at negative. Gram stain culture, there was no growth. Fever profile also negative. Viral serology also negative. But CRP was high 129. Procalcitonin within normal limits. Blood culture report shows no growth. Urine examination reveals nothing abnormalities. That was the chest CT scan thorax. Bilateral multilobar consolidation, pleural vest lesion, along with there is mediastinal lymphadenopathy mainly in the 4R location. This is the CT thorax showing bilateral multilobar consolidation. Now, what should be the next investigation? Obviously, FNAC from the right supraclavicular lymph nodes, and that shows there is ill-defined granuloma, suggestive of granulomatous inflammation. At the same time, AFB smear and CBNet from lymph node aspirate was negative. So, what should be the next investigation? Either lymph node biopsy or bronchoscopy. We did bronchoscopy with Balfour study, and that reveals normal. CBNet, gram stain culture, fungus stain culture normal, and galactomannan also within normal limits. At that time, CITB test was positive. This is the histopathology of excision biopsy of right supraclavicular lymph node, and it's showing granulomatous inflammation with necrosis, but there is no KGSN seen. So, what are the possibilities from this history, clinical examination, histopathology, along with radiological examination? So, as there is fever, granulomatous inflammation of lymph node, bilateral consolidation, so first will be the infective, either tuberculosis, histoplasmosis, brucellosis, as there is Brucella serum agglutination test was negative. The next investigation is the autoimmune profile that reveals only ANA2 plus nucleolar pattern, anti-CCP ANA profile, ANCA, SASE, all are negative. Then we also thought about that may be a case of histoplasmosis. We sent the blood, we sent the urine for histoplasma antigen, and it was also negative. So at this moment, either we should start ATT or not. As the clinical features granulomatous cervical lymphadenditis, bilateral consolidation, and along with CITB positive, and also patient not given consent for TBLB, we have started ATT for this patient. But what happened after 1 month? There was no clinical improvement, no radiological improvement. Rather, there is radiological deterioration that's showing bilateral consolidation, and that is more profound than the previous one. Along with there is anemia, hemoglobin 7.9, but the LFT and urea creatinine raised, SGOT, SGPT raised almost more than 5 times. Creatinine also raised. As the urea creatinine raised, we sent urine routine examination, and that reveals protein 2 plus RBC 15 to 25 per high power field, but no RBC cast was present. If we see the two X-ray 1 month apart, you see that there is clearly radiological deterioration seen. So either we should continue ATD or review the diagnosis. Obviously, as there is no clinical improvement along with radiological deterioration, we stop the ATD. Either the LFT or urea creatinine that due to anti-tubercular drugs or due to disease itself. So next we plan for transbronchial lung biopsy or renal lung biopsy. As the patient not given consent for TBLB at the time, we plan for renal biopsy. Simultaneously, we also sent blood for repeat ANCA profile, and that revealed C ANCA 3 plus along with BR3 261. This is the report, and then we have treated the case with immunosuppression therapy, pulse methylprednisolone along with injection rituximab, and you see that there is clearly improvement, radiological improvement after 1 month of immunosuppression therapy. So there is X-ray sequentials, ATD started, there is radiological deterioration, then we started immunosuppression therapy, there is remarkable improvement of radiological parameters. Simultaneously, we have started tubercular preventive therapy. And there is a question, either we should start TPT or not. But if the patient only receives rituximab, then the TPT prophylaxis is not needed. But at the patient received high dose corticosteroids along with rituximab, so there is always chance of reactivation of tuberculosis. That's why TPT was started along with the pneumocystis prophylaxis. At that time, we did renal biopsy, and that shows necrotizing crescentic glomerulonephritis, and crescents 63% of the glomeruli are involved. And there is direct immunofluorescence studies shows low intensity mesangial staining for IgG, IgA, C3, and C1q. That is very much unusual of the ANCA vasculitis. Though ANCA vasculitis is associated with Purkinje granulonephritis, but there is glomerular immunocomplex in ANCA-associated glomerulonephritis is well recognized phenomenon, and that deposits are thought to influence the pathogenicity of ANCA. So, as the case was ANCA-associated vasculitis, we also did CTPNS for supportive evidence, but it reveals nothing abnormalities. So our final diagnosis was ANCA-associated vasculitis with pulmonary renal involvement. So what's the importance of this case? As the presentation is very rare in ANCA-associated vasculitis, and it is very much closely mimicked with tuberculosis, both clinically, radiologically, and histopathologically. The important point is that dynamic ANCA positivity, a single negative ANCA does not exclude ANCA-associated vasculitis. When there is high clinical suspicion of ANCA-associated vasculitis, always do repeat ANCA profile along with MPOPR3 titer. That case demonstrates evolution from isolated pulmonary disease to pulmonary renal involvement, and the timely immunosuppression changed the outcome of the patients. Thank you.